Lights, yep. Camera, Then action. Well, here we are. G'day, I'm Ted Jedynak. Yeah, it's a birth defect. Welcome to today's Triple T TV show, Ted's Tips on Tuesday. In today's TV show, you'll discover how to get better Achilles results without treating it. What? What do you mean? We've got a problem that we're treating, but we're not going to treat it? Yes, and I've got some few head spins and brain twists to work through today, so I think you're going to enjoy today's show. If you don't know me, I've been helping health practitioners all around the world to fix more feet using manual therapies as a treatment option since, 1994. Crikey, that's going back a while. Look, I've been utilising manual therapies specifically for over 22 years, so I've had a fair bit of experience. Got a few runs on the board and a bit of water under the bridge, and that's about all the analogies I can come up with. But in my time as a practitioner, I've seen what works and what doesn't, and I'm dead keen on helping you get even better clinical results for your MSK cases. If you're a physio, podiatrist, chiropractor, osteopath, remedial therapist, and have got more than 5 digits on one hand, then welcome, you're in the right place. Thanks for joining me here live from my office in South Australia. I was going to say sunny South Australia, just the difference today is that the sun is on the other side of the rain clouds, but you know, that happens, we need it, it's winter. Now, if you've ever had an Achilles case that didn't fully resolve or go to plan, let me know. Just give a quick thumbs up or maybe a sad face. Your feedback, it'll ensure that I give you relevant and practical tips to help you with your TA Achilles tendon cases today. If you ever got to the point where you had to refer Achilles tendinopathy cases out because you had nothing else to offer, please hit, the thumbs up, that's me. I certainly referred a lot of Achilles tendon cases out before embracing manual therapy techniques for fixing feet. You see, when I graduated from university, the only tool that I had in my toolkit was orthotic therapy. So when I went into private practice, I had a rather rude awakening. I quickly discovered that orthotic therapy didn't fix everything. So it became crucial to my clinical outcomes that I skill myself in other treatment options. But you know, I stumbled about in the dark probably for quite a few years. And in that time, I had to refer a lot of clients out to other practitioners. It wasn't until I stumbled on foot mobilization that it was then that I began to fill in some of the missing pieces in my education. Manual therapies completely transformed my clinical outcomes, and that's why ever since I've dedicated my career to helping health practitioners, just like me, fill in those missing pieces in their education. We had a fabulous show last week. It was about this tool that we use as part of our manual therapy treatments. A record number of people downloaded the freebie. The freebie was all about how tool-assisted massage as a tool can assist in resolving some of those stubborn cases that don't quite go to plan, or those cases that people get better but not best. The post and the freebie, it's still available. All you have to do is just scroll down on this page to last week's post and you can still claim it if you haven't got it already. It's all about manual therapies and using the tool for medial tibial stress syndrome. And that can certainly be a condition that gives us all the shins from time to time. Now, you'll remember how in last week's show we dived into the tib post and the navicular and my favourite mobilisation technique for treating medial tibial stress syndrome and also tib post tendinitis. I discussed the physiology and the biomechanics of navicular displacements with some assistance from my assistant Penny Lee. She's poised there. I think she's just waiting for her opportunity to pounce. We better look out. Okay, so all of these tools, the mobilization, the use of, and the importance of treating the navicular, it's all mapped out for you in the fabulous freebie. So please, if you haven't got it, make sure you get a copy. Today's sensational show, well, it's all about how to fix Achilles problems without treating it. Now, it's not quite a play on words. It's going to make all sense in just a few short moments' time. When I asked the FMT family what they wanted help with, the overwhelming response was they needed help getting a new cat. And I suppose they had a bit of a tale to tell. Oh, that's a new one there, which is right here. No, they certainly had lots of tales to tell about the Achilles frustrations that were affecting their clinical results. This is because the Achilles can be such a resistor to our traditional treatments. I did a quick check yesterday in preparation for today's show, and there were requests from Alex, Marie, Barbara, Joanna, Paolo, and Baram Jam, respected physiotherapy educator in Canada. Marcus, we also had James say Achilles were giving him a fair bit of problem. So I'm going to turn your world upside down today in true Aussie style, particularly for our Northern Hemisphere colleagues. In fact, just this morning, Tassie from, Tassie, I've forgotten where you're from, an international guest, international practitioner, also had a request for a problem with an Achilles patient that she was experiencing currently. Tassie, today's show is dedicated to you. Yeah, I know, and to you as well. All right, so how are we going to fix Achilles problems without even treating it? Is that an oxymoron? No, let me explain. You're thinking, surely you've got to touch the thing to do a treatment effectively, don't you? Well, it's not going to be exactly how things are going to work today. First of all, let's define Achilles tendinopathy. Now, Achilles tendinopathy, I'm going to use a quote or reference from Klein and Baxter. And that is, Achilles tendinopathy is a common overuse injury where I know some people get really peeved off when their Achilles problem gives them troubles, and now I'm really worried because I think I'm going to be attacked. So let us say, come on, let's play down here. Oh, jeez Louise. All right, so Achilles tendinopathy. It's a common overuse injury caused by repetitive energy storage and release with excessive compression. This can lead to a sudden injury or, in the worst case, cause a rupture of the Achilles tendon. In both cases, a lack of flexibility or a stiff Achilles tendon can increase the risk of these injuries. Now, let's take that information and put it in our clinical situation. What are the classical clinical signs of someone with an Achilles tendinopathy? Morning pain, that's a hallmark symptom, and that's because the Achilles tendon gets exposed or forced to go through its full range of movement, including stretching out immediately when you get up in the morning or when the patient gets up in the morning. Symptoms are typically localized to the tendon and the immediate surrounding area. Swelling tends to be less common. The tendon can appear to have subtle changes in it. There might be differences in the outline. Some parts might be thicker, and you need to look in the anterior, posterior, and medial lateral planes. This is summarized by Cook et al. In their research paper. Now, when you're dealing with the Achilles tendinopathies, the differential diagnosis, that's absolutely crucial. So let me just run through the list of the conditions that you need to differentially diagnose to make sure you're dealing with a true Achilles tendinopathy. They include plantar fasciitis, calcaneal fracture, or stress in the like a stress fracture within the calcaneus, heel pad syndrome, Haglund's deformity, posterior ankle impingement, medial tendinopathy, We've got retrocalcaneal bursitis, sural nerve, and also lumbar radiculopathies, ankle osteoarthritis, DVTs, partial Achilles tendon ruptures. There's quite an extensive list of conditions we need to differentially diagnose. Did you get all those? Did you remember them? Did you write them all down? No, maybe not. So I've got this full list all mapped out for you in today's fabulous freebie. So you can have a ready checklist that you can just literally tick off and make sure that when you're doing your initial assessment, if you're suspecting an Achilles tendinopathy, you can rule out these other cases. Okay, so what's new? What is this business of fixing Achilles problems without actually treating it? Are you thinking Reiki, faith healing, maybe psychic surgery? You're probably wondering, Jedynak, has he slipped off the reservation? Well, maybe he was actually never on the reservation in the first place. So let me quote some of the experts in myofascial medicine and manual therapies. The Stecco family from Italy. It's father and Angelo and Carlo and son and daughter who've done some tremendous work in the field of myofascial manipulation. There's also Tom Myers of Anatomy Trains fame, so from past episodes. So you see, this is an excellent text to refer to. There's also Professor Helene Langvin. I think she's a histocomologist. No, I don't know. Sorry, I made that word up because she does a lot with histology, the biochemistry. She's actually a professor of neurological science at Medical Harvard School. So, not too shabby as far as reference and standards go. Okay, so common theme from all of these specialists, and that is MSK conditions like Achilles tendinopathy. The site of pain is rarely the site of dysfunction. If you only get one thing from today, that's the key. It's like where the pain is usually an effect, and the cause, the site of dysfunction, particularly in the myofascia, is elsewhere in the body. What they state is that the site of pain is usually the weakest link in the chain. And we're talking about the myofascial network, the whole web that encompasses the whole body. Look, I learned basically nothing as far as the myofascial web in my university training. In fact, my first experience of fascial work, this was when I undertook personally a course in Rolfing. Now, has anyone experienced Rolfing? Have you ever heard of Ida Rolf, the practitioner who founded Rolfing? If you have, just send a thumbs up so I can speak your language and maybe refer to some of my experiences. My Rolfing practitioner, she was a moderately petite lady, quite athletic in physical stature, but she very quickly developed the deserved nickname of Barbara Ballbreaker. In fact, I can't even remember what her surname was, but I sure as hell remember what she did to me. Oh, no, Barbara Ball, that's right. Sorry, that was a little bit too obvious. Before I had my Rolfing work done on me, I was only 5'10" as far as height goes. In over 10 weeks after Barbara was finished with me, I ended up being 6'5". So that's kind of the impact of Rolfing. I'm messing with you a little bit there, but...
You spent a lot of time crying.
I spent a lot of time crying. Her thumbs, fingers and elbows got into places that I'm just sure... Now, one of the things she did was actually work on the anterior aspect of my spine. But this is like going through the stomach between the... Like, it is freaky stuff, amazing. Now, one of the... I suppose Barbara's role and her work as a Rolfer, it's lived on. Ida Rolf actually passed on in 1979, and so a number of therapists have continued to research her work, Tom Myers in particular, and also the Stecco family. They've certainly built their work on Ida Rolf's shoulders. Now, one of the key models that helps us understand the myofascial web and how it affects conditions like Achilles tendinopathies is the model of tensegrity. And this is pioneered by architectural genius Buckminster Fuller. To summarize this model, it works on the premise that the whole MSK structure is interconnected, literally via the deep fascial network. There's a great party trick that I sometimes do in our workshops to literally demonstrate in practical sense how this fascial network actually works. It's a demonstration of how we can release our hamstrings by doing a foot exercise. So it's like treating the hamstrings without even touching the hamstrings. Noticing the theme here? What we do is, over a 2-minute period of time, we work on the foot. And we do a baseline test, people touching their toes, seeing if they can reach their toes, do the 2-minute treatment on the foot, and then they go to touch their toes again. And literally the hamstrings and the low back muscles have released, and the amount of movement that has been gained, or the additional movement, is absolutely phenomenal. It's a total belly button popper if you've never seen it happen before. So I've included the link in the freebie of this exercise and the demonstration. And you can try it at home too, once you see how it's done and what materials you use. Okay, so there are 4 types of fascia. And for us MSK practitioners, we're going to focus on the deep fascia. So this is tough collagenous stuff that wraps around every muscle, ligament, bone, tendon, capsule. And it wraps around these structures to enable all of those structures to slide and glide against each other. Now, the reason why this is different from the typical anatomical model that we're taught is this. So what we're traditionally taught is the skeleton is made up of rigid levers. So we'll have the bones that are the rigid levers, and then muscles that generate movement to move those levers up and down or in certain directions. If we use my arm as an example, so my biceps and my muscle, maybe a little bit of a feeble example of muscle, but the forearm is the lever, and so when I contract the muscle, the lever comes up. Okay, so that's literally how we're taught traditional anatomy. Now, the thing that happens with that, as the arm gets pulled up, the muscle contracts, the muscle gets bigger. All right, you're going to have to take it from me. My muscle does get bigger, even though you can't see anything happening here. Are you going to say it gets bigger? Yeah, it gets bigger. All right. Then, if we actually do the opposite and elongate to the muscle, as the lever goes away, the muscle literally shrinks and gets thinner as far as the bulk goes. Okay, so that's the basic premise of how it works. Now, when we talk about the tensegrity model, everything changes. Oh, in fact, don't go away. Yes, I had to put this away, my tensegrity model here, because someone just loves the rubber bands and chewing on it. Okay, so simple terms, lever, muscle. As the lever contracts, muscle gets bigger, so as the lever gets pulled up. So from a tensegrity perspective, if we were to do the same thing where we were going to elongate the levers. So with the tensegrity model, the sticks here are essentially the bones, and then the rubber bands are like the flesh or the fascia that holds everything together. Part of the tensegrity model is that the bones sort of float within the myofascial web in the network. So where we saw, if we were to pull the bones apart with my arm, the muscle bulk would reduce. If we bring those levers together, the muscle bulk increases. When we do that on a tensegrity model, watch what happens. I'm going to pull these guys apart here where my hands are, and watch these horizontal beams go across. So I told you someone was interested in this one. Here we go. Hey. Oh. Come on. Thank you. Here's the demonstration. When I pull them apart, look what happens. They actually get bigger. They expand out. Can you see that? Whoa. Now, what happens when we contract? If we were going to contract and make the bicep bigger, these technically should expand out. But watch what happens here. Penny, you're watching very closely. Push them together, and they also contract down as well. Pull out, they expand. push in together and they contract. And what happens is as we move one lever, every other part of the web has to respond to some degree as well. So it's not isolated to lever and fulcrum. It is actually an interconnected web of structures. Now, this is a paradigm shift in how, and this is part of the key reason why we are going to treat the Achilles tendon without actually touching the Achilles tendon. You see, remember how I said that the site of pain with the Achilles tendon is not the site of dysfunction? Well, the myofascial principle goes like this. If the site of pain is the Achilles tendon, there must be myofascial restrictions or adaptations or fixtures somewhere else in the myofascial web that's causing the Achilles tendon, which is the weak link, to react or break down. Does that make sense? You see, it's a way to explain the kinetic chain of how the body works. I mean, you've had cases where you've used an orthotic device at the foot level, and you've helped conditions higher up the kinetic chain. You might have helped the knee, the hip, the lower back. If you've had a case where a different condition than what you're treating at the foot level has actually improved, just give me a thumbs up. Make sure that I know we're speaking the same language here. So, anytime you've treated the foot or you've treated using orthotic devices, have you been able to help a structure in higher up the chain? Let me know. That would be good. I can remember a client, Lorraine. She really lovely lady, but a bit of an interesting bird as well. It got to the point where she was coming to see us for foot mobilization treatments because it was the most effective way to help her shoulder pain. And when she first told me this, I thought, man, that's just a little bit weird. And I had no idea how this could possibly work. But then got into anatomy trains and Tom Meyer's work, and it started going a long way to explaining just how that exact thing happens. Great, thank you very much for those of you who have experienced benefits with treating other parts of or affecting other parts of the body by working on the foot. All right, now, the upshot of all of this is Achilles tendinopathies. What you need to do is you need to assess and examine the myofascial structures. Got the Achilles tendon, assess and examine the myofascial structures proximally and distally. They're the other where it's most likely that the dysfunction or where the compensation is actually occurring. So where you've got the site of pain or injury, you need to go proximal and distal. The way you do that, and this is where these tools just come into their own. You see, they enable you to assess and screen muscles, ligaments, tendons, fascia in a very quick and very efficient manner. And that's totally game-changing for MSK practitioners. It certainly was for me and for my students who have embraced the tool-assisted massage and soft tissue mobilization techniques. So what you do is you examine the myofascial tissues that run proximal and distal, and let me just check that I've got some here, there. So you examine and the tissues proximal and distal to the painful site. Now, in the Achilles tendinopathy cases, the proximal structures are the calf muscles, but also the hamstrings and even the glutes and the paraspinal muscles. So you can literally venture right up the kinetic chain to those areas that are going to be directly connected through the fascial web into the Achilles tendon. And then you need to go distally. And so distally you go into the plantar foot muscles, the plantar fascia, and particularly with the Achilles tendon into the big toe. And here's the kicker. You must carefully examine the antagonist muscles too. So in the Achilles case, the antagonist muscles will be the extensor hallucis longus, extensor digitorum longus, the interossei muscles, and the tibialis anterior muscle. You also need to make sure that they are looked at closely, because when you find fascial restrictions in any of these structures, you treat them first and not the Achilles. If there's only one thing you get from today's show, that's the thing. I know that's the second thing you should get, but it's the critical thing. Someone comes in with a painful area, you are actually going to treat proximal, distal, and the antagonist muscles before you touch it. You don't touch that on the first visit. You see, if these other structures are the cause of the weak link of the Achilles, then releasing those structures will then reduce the compensatory tension at the Achilles tendon. Won't they? Does that make sense? See, and second thing important to be mindful of is that if you've got an Achilles that is painful and you start treating it, like you might be doing some releasing or stretching or some massaging, what are the chances that you're going to aggravate that already painful site? What do you think? Psst. High? Low? Yes, they're high, aren't they? Very high. Look, she's looking very high. Okay, she doesn't want to have those conditions aggravated. That's really crucial. If you aggravate those, you're going to have a very unhappy customer as well as a very unhappy feline, and now I am getting a little bit concerned. All right, so what do you do for your clients and their Achilles problem? Well, you take the cat away and you treat their Achilles area on the second visit once you've checked in with them. See, when they come back in on their second visit, you inquire as to what their pain levels are with the Achilles. Their answer will help you determine what the true cause of their Achilles pain and where it was actually coming from. I can tell you, you will hear about 60% of your clients report a noticeable improvement in their Achilles pain and symptoms after their first treatment when you didn't even touch the Achilles. That's, in my experience, it's like more than half people you treat other areas that actually notice an improvement in the weak link. That, you hear that noise? That's people's belly buttons going from an innie to an outie. When it happens, first time you'll think it's a little bit freaky, the second and third time you think, maybe there's something in this. Okay, now, being the intelligent soul and practitioner you are, I know you're probably wondering, well, how the heck does that work? I sure wondered that too, I can tell you. There's an early model of fascial release. It was pioneered by a guy by the name of Jedynak, and this is about 50 years ago. It's essentially the basis of transverse friction techniques. So you might have heard of transverse friction, you might even be practicing transverse friction. If you've heard of transverse friction, just give me a thumbs up to let me know that, yep, transverse friction, heard of it or know of it. So what transverse friction was, it still is, it's where you apply a therapeutic force 90 degrees to the direction of the fibers. So if we've got the fibers of the Achilles tendon running literally from superior to inferior, we would apply transverse friction 90 degrees, so literally transverse to the natural grain or the fibers of the collagen fibers within the particular structure. In the Achilles tendon, that'll be in this direction here. This idea is, the idea of the Jedynak treatment is that it causes micro trauma, and that enables or stimulates new collagen fibers to reorganize and repair themselves in a better manner. It was probably, it might be 10, 15 years ago now, that this thesis came under pretty intense criticism. The good news is that recent research shows that this type of treatment method, it does actually work. It's just the mechanism and how it actually works and how it creates those structural changes and what happens to the fibroblast activity, that is now better understood. So maybe a little bit like orthotic therapy, we're still having questions about, well, how does it actually work? While the research still worked that out, we know it works from a clinical perspective. We see that every day. Well, that's what was happening with the Cyriax method. The understanding of the mechanism of action has certainly improved. The Professor Helene Langevin, she's a crucial player in the biochemistry and the research on fibroblast activity. I've included a link to her work, which helps if you want to understand the mechanism of what happens to fibroblast collagen production. Her work is absolutely groundbreaking and world-leading. The Steccos in Italy, they also discovered the histological changes that happen to the hyaluronic acid in the extracellular matrix. Now, the hyaluronic acid hypothesis for fascial dysfunction, it offers a clearer explanation of how fascial restrictions that we as practitioners often palpate, we can feel the lumps, bumps, like what are they? Those restrictions, the hyaluronic acid, they get beautifully explained by the work by Steccos. So I also included a link to their work because that is absolutely, so this is all in the freebie that you're able to download at the end of this show. All right, now, Mareme, welcome. Good to have you on board. Maybe I can, this will be timely for me to address some of the critics of tool-assisted massage. And if right now, if you have a question about what fascial release is, or have you ever come unstuck or wondered about how myofascial release works, please type them in. I'll be very happy to address those for you. I'm going to take this opportunity, though, to make sure that I address some of the critics, because there certainly are. In manual therapies, quite a bit of discussion and debate that goes on. All right, so let me just go through the first one that's common criticism of fascia that is raised. That is, fascia cannot be mobilized or stretched due to the non-elastic nature of collagen fibers. So therefore, manual therapy doesn't actually modify fascia. Kind of makes sense, bit of a strong argument, isn't it? And it's true. In the research, in situ laboratory tests, fascia, the fibers, are extremely resistant to stretch. However, you might have remembered me saying earlier is that we're not about stretching the fascia. We're looking at the gliding and the mobility of fascial linings to be able to slide and glide against each other. So the fiber, what we need to ensure that it takes place is when those bundles and fibers can slide against each other, that's where different connective tissues like tendons, the tendon sheath, they're certainly modifiable, and they're absolutely modifiable through practitioner techniques. And that's how the tool-assisted massage works. Improves the glide between the structures to enable that mobility. Another criticism of the tool-assisted massage techniques is that inducing micro-trauma to stimulate connective tissue regeneration, as I mentioned with Cyriax's work, takes too long to be clinically effective. You know what? True, it does take time. And because of the cellular turnover rate, particularly with collagen fibers, we're typically looking at a 6-week treatment plan. Let me ask you this though. Why would a few weeks be an issue when many Achilles problems that we see have been there for months or even years? I can remember a client, Maureen, and she had a 2-year history of chronic Achilles tendinopathy. She was so desperate, she was actually at the point where she was going to sell her home because climbing stairs, she could no longer tolerate that. We were, over that 2 years, it wasn't like she was ignoring herself. By the time we saw her, she'd been to 4 practitioners. We were the 4th clinic that she went to get resolution or improvement with it. So we'd seen her and did our assessment. And I can tell you, 4 weeks after we began the treatment for Maureen, she was reporting a 90% improvement in a 2-year chronic condition. 3 months later, she is completely asymptomatic and climbing her stairs comfortably and loving the family home. See, sometimes you've just got to look at things from a different angle, don't you? Another criticism is that trigger points, what the heck are they? So the criticism of manual therapy is that trigger points don't exist. It's a theory and it's never actually been proven. My response to this is it's basically a semantic argument. The myofascial phenomenon is known and seen by many professions. It's described in a number of different ways. There are fascial densities, restrictions, fibrosis, it's a fascial barrier, or there's hypertonicity in the area. Some practitioners will even talk about the chi or the blockage of energy. Pick your favourite word to describe all of the things that we see as a clinical presentation. But I invite you to be open to the varied clinical experience and even the language that other manual therapy professions use. Because from a clinical perspective, and now the research is definitely supporting this, there are key benefits and advantages to releasing those fascial restrictions so that we can restore that glide and slide with each other in the kinetic chain affecting those symptomatic sites. Make sense? If it does, give me a thumbs up. I know you're on board. If there are any questions, if you're not sure about what I've covered, or if you had a question about any of the material that I've covered, please type them in. Be really happy to address those for you. Okay, so let's see questions. Okay, how long or how often do you do this treatment for? Great. Okay, so I briefly touched on the healing cycle, or the natural turnover of collagen fibers, and that will typically take, the research tells us, it takes around 6 weeks from old damaged cells to be replaced with new healthy cells. So that 6-week cycle is typically what a treatment plan would happen. But the lion's share of the work happens in the first 3 weeks. You've got to get those adhesions, restrictions opened up, get the fibroblasts stimulated, get the new collagen fibers lined up in the directions of stress, and get people moving and get the mobility happening as quickly as possible. In those first 3 weeks, seeing people and working on those fascial restrictions twice weekly has been shown to have the best clinical outcome, best clinical result. You may remember from previous shows how we've talked about the 3 phases of soft tissue rehab: stretch, strengthen, and stabilize. This is the stretch phase of that treatment. So it all incorporates. Also, tool-assisted massage has been shown to work very effectively in conjunction with other MSK treatments. So independently, I probably wouldn't recommend it. I would certainly recommend you combine it with your other treatments, whether that be orthotic therapy, gait retraining, exercise therapy. It's definitely an adjunct service that works, but certainly gets your clients' clinical results progressing most effectively. Okay, what if I don't have a tool? Get one. Literally, I mean, you can do this work with your hands. Remedial therapists, massage therapists, this is literally the work that they would do with their hands, but it does take a toll on your physical structure. So, and then professions like mine as a podiatrist, where we don't get very much, if at all. I certainly didn't get any palpation or manual therapy training. The tool is a great thing because what it does is it's an amplifier. It means it literally magnifies or amplifies any fascial restriction. So if I'm working on tissue and sliding it across, a bit like the needle on an LP record player, it will pick up the feedback of any areas that are restricted, and then you can identify what actually needs to be worked on and use the appropriate treatment. So that would be the perfect thing to do. Okay, great. So in this week's freebie, we got some great stuff lined up for you. For those of you who've just joined, let me just quickly summarise what we've covered. My name's Ted Jedynak, but we can still be friends. Today we've explored the therapeutic value of tool-assisted massage for Achilles tendon cases, and specifically how to treat the Achilles tendinopathies without actually touching or working on the Achilles tendon. We've also got quite a bit of material on how the myofascial web works. We used a demonstration of a model that I think Penny has probably chewed up to pieces now, the tensegrity model, where we were able to actually look at what we could do to stretch, elongate different parts of the body so that we could affect those structures that literally we work on here, but we can see different parts of the body responding. In fact, when we work on one part of the body using the tensegrity model, we cannot not influence the other parts as well. So that helps explain what goes on. We also dived into the physiology of the fibroblast activity. We also looked at hyaluronic acid hypothesis and how we get those fascial releases so that we can improve those Achilles and myofascial conditions too. So please make sure you get a copy of the freebie that I promised to you. In this freebie, we've got a ton of great stuff for you. First one is actually listing the differential diagnosis of Achilles tendinopathy. So if you've got an Achilles tendon case, there's someone coming in, painful area in the Achilles region, here are the conditions that you need to differentially diagnose so you can be sure that you're actually treating the most appropriate condition. Great to have a checklist here. Have it by your desk and tick them off as you go through. Also, the typical treatment options that these conditions would have. We've got right down here the typical treatment options for Achilles tendinopathies. So when we've got the list of conditions, if you're using one or more of these and you're still not getting the desired clinical results or outcomes, then you know you've got to move on. Also in the freebie list, we've got this one here, which is the key elements of the new treatment assessment option that we've been discussing today, and this is the use of the tool-assisted massage. So using the tool, and I've got a list of the different techniques here, from a diagnostic scan, we've got the warm-up that we do pre-treatment, we've got the deep fascial release, which is based on Travell and Simon's work from, that's probably going back into the 80s, and also cross-friction work, Syriax's work. They're the key fibers or the key treatment techniques that we would be using with utilising this tool. We also love to, I think we got all things. I mentioned here about the useful links. So under this section with the useful links, what you'll see here, the demonstration that I promised relate how you can release people's hamstrings by treating the foot only. So YouTube link is there. We've also got Helene Langvin's reference in regards to the fibroblast activity, the Stecco family and their myofascial manipulation work. Tom Myers, great text, really is groundbreaking material on the anatomy trains. And all of that good stuff. Now, we've certainly got a number of inquiries here about, well, how do I learn about the tool-assisted massage and the myofascial release treatment if I've not learned this stuff before. Our workshops in Europe are now pretty much sold out. So that's good news for those who are joining. But for those of you who haven't been able to get on board, then unfortunately, we won't be able to provide that live training for you. We have a live training coming up in November the 18th, here in Adelaide, Australia. So that's definitely, we've got the link and those details right at the bottom of the freebie if you want to equip yourself with a tool-assisted massage and add that as a treatment tool in your toolbox. We are also working on an online training program too. So we're expecting that will be up later in the year. If you're interested in that, please make sure you're in the list of the FMT family members, and we'll definitely make sure you be the first to know about the upcoming courses that will be available for you as well. To get onto the list, just click on the website page at footmobilisation.com, and a box will come up and you can enter your details, and we'll make sure we keep in contact with you. Okay, so before we sign off, are there any other questions? Please feel free to type those in, and they're happy to hang around and help you out. Until that happens, I'd like you to please join me in saying a great big heartfelt boom, 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 thank you to Dr. Lil for piecing together all of the content and the background information that goes into putting together our weekly Triple T TV show for Ted's Tips on Tuesdays. I hope you found this beneficial. If there's something that you're going to do differently right now as a result of this show, please type that in. If you're watching a replay of this show, then what you'll find is the link to the freebies and also to any of the content here straight above my head. You can also add in a comment there. We keep track of the comments, so if you're watching a replay, I'll certainly respond to those as well. If there's anything I can help you with, be very pleased to do that. Okay, so until next week on the same bat time and same bat channel, do as my mate Matt Rimmer on the Gold Coast says, if you want to stay ahead, catch up with Ted. Look forward to catching up with you next week. It's been a blast, and I look forward to sharing some tips with you next week on Morton's neuromas. I'm going to be drawing on the resources of a good friend and colleague Dave Cashley in Scotland. Dave is an absolute expert and in the manual therapies, foot mobilisation, foot manipulation techniques for conditions like Morton's neuroma. It's involved in some very exciting research as well, going to help shortcut your path to treating neuromas by drawing on Dave's resources too. So until next week, make sure you take your skills to the next level and fix more feet like never before. Cheers.